So I'm writing notes after a shift. Some people call it haiku notes. And I hear, yo, code heart. EKG you'll see at the end of the video that I'll add was scary, and there's a comparison. Having chest pain and history of hypertension. I don't think she has any known drug use, and she looks uncomfortable. So code heart usually means transfer or consider giving lytics like T in case, not TPA, but T in case, or coordinate quick transfer to a patient. If you load them up with either aspirin or Brilinta, give them heparin or Lovenox, load them with aspirin, and make sure they're stable hemodynamically. Blood pressure not too high, not too low, not on frank CHF, really stable for transfer. Writing in notes, I see the EKG like, whoa, looks real. And then while writing my notes, I hear seizure, in the same location where a patient is being treated or being assessed for a heart attack. What? This sounds similar to something I've seen. I go in the room and patient's like, so it's not the classic tonic-clonic type seizure, but something is showing low flow to the brain. And I look at the monitor, always look at the monitor. And if she wasn't on one, you'd have to feel for a pulse and put her on a monitor. And she had something, you'll see at the end of the video, that goes like this. Ooh, ooh, ooh. That's a funny looking VTAC. Polymorphic VTAC, classically called torsades de points. Make a line with some curves and twist it, and you look weird and awkward. Patient had the mini seizure, and it stopped and felt no pulse. Boom. The worst that can happen with a patient that I couldn't feel a pulse because maybe I was too much in a rush while doing CPR, she'll grab my hand, she'll look at me and say, stop. But I didn't feel a pulse. CPR going on. Craziness, right? Craziness. And then I was like, yo, 2 grams of mag now. Stat. Push. And she needs to be on a monitor. Of course, I'm wearing rubber-soled sneakers. I should be wearing gloves, but I was in an emergency. There's no blood or bodily fluids there. Put the pads on. Pads on the left lateral. It has to have an arc. Like left side, right? Left side of chest pain. It could be AP or and light them up. Crank it up to 200. And once it's primed and once it's charged, 1, 2, 3. And then go back. Don't feel for a pulse. Signs of life would have been, she grabs, again, shows signs of grabs me, looks at me, starts talking. Some cardiac monitors now can actually read through despite the artifact of the CPR. So you can actually see if it's a torsades or not, or any other arrhythmia while you're doing this, despite the motion artifact of the CPR. Some don't. And you have to rely on the 10-second pause after 2 minutes. After 2 minutes, on the monitor, still in VTAC, polymorphic, torsades. She's getting the 2 grams. I don't care if it's over 10 minutes. Fuck it, she's dying. Push it. I'll deal with the consequences later. It's the oldest, one of the oldest OG antiarrhythmics, magnesium sulfate. It's not 4 grams, 6 grams that you give for like eclampsia. Pregnant women with seizures, right, with hypertension, right? We shock her again. We feel a pulse, boom, coming back. And you look at her, instead of her being like glaciated, comatose, she starts turning her head and looking around. And she's now normal sinus, back with a STEMI. Not because of me, she had the STEMI. The STEMI likely induced because of lack of flow to some part of the heart, an arrhythmia. And you can check your mag levels, potassium levels, calcium later on. But she had an emergency that needed CPR and electricity. Witness arrest is the best arrest. The best chance to take that patient from the Grim Reaper and say, hey, not today. And smile at death and say, not today. Because death smiles at us all, and all you can do is smile back. Not today. Not today.